Secretary, and let me go ahead and make an opening statement, and then we'll move on from there. So again, good morning, good to have you here. It's my pleasure to welcome you to the Subcommittee on Labor, Health, and Human Services and Education for our very first hearing of the year, and my first hearing as chairman, so I'm honored to be able to share that with you and looking forward to your testimony. I want to add quickly on a personal note, I had the opportunity to meet you thanks to my good friend Mr. Womack some time ago, and facilitated that relationship when you were at OMB, and I want to tell you how much I admired and appreciated your services there, working with you in your current capacity when you had the challenge of the influx of illegal immigrant children in the summer. You were extremely helpful. I had 1,200 of those, or up to 1,200 that were going to be stationed at Fort Sill. You worked with us very well. So again, my experiences with you have all been positive and productive, so it's great to have you here. As I've been coming up to speed as a new chairman, I've been learning more and more about the astonishing range of programs under your jurisdiction. From overseeing research that we hope will cure diseases like cancer and Alzheimer's, to protecting our people from Ebola and the flu, to providing child care and early learning to our youngest Americans, to training our next generation of medical professionals and administering health insurance for our nation's poor and aging populations. Your responsibilities are broad, great, and numerous. There are many things in your budget that I think we can all agree are priorities and that we can collectively support. There are others that where we may well disagree. The challenge that we'll be facing this subcommittee is how we can support the most critical programs, the investments that will give Americans the greatest bang for the buck, so to speak, with the limited resources that we will have available to us. Your budget assumes an array of tax increases, new user fees, changes in mandatory spending, and other spending sources that are beyond the purview of this subcommittee. You use these funds to pay for increases in popular programs. In my opinion, we won't be able to do everything you're proposing. I look forward to having a discussion with you this morning about the top priorities in your department. From your perspective, where should we actually invest the taxpayer dollars that are at our disposal? If we can't fund everything you request, where would you prefer us to focus our limited dollars? I would also be remiss if I did not point out many of the management challenges facing you at the helm of HHS. From the continuing problems with administering Obamacare to contracting irregularities, backlogs, and complaints from medical professionals, there seem to be no shortage of areas in need of managerial improvement, an area, frankly, at which you have proven repeatedly you excel. I hope to learn more this morning on what you're doing to take positive steps in these areas and where we can assist you. Finally, there are many external challenges facing your agency: threats to cybersecurity, threats from diseases like Ebola and antibiotic-resistant bacteria, and the many challenges of poverty also land at your doorstep. I look forward to hearing your ideas on how to combat these this morning as well. As a reminder to the subcommittee and our witness, we will abide by the 5-minute rule so that everyone will have a chance to get their questions asked and answered. Before we begin, I'd like to yield to the gentlelady from New York, our ranking member, for any opening statement she would care to make. Or yield to the ranking. Yes, ranking member of the entire committee.
Ah,
and then,
okay.
Sorry.
Welcome. I'd like to thank Chairman Cole and Ranking Member DeLauro for holding this hearing today. Chairman Cole, welcome back to the subcommittee. It's been my pleasure working with you on these issues, so many other issues. I look forward to working together. And certainly with Chairman Rogers, Ranking Member DeLauro, to continue funding these important investments. And to Secretary Burwell, we are so pleased to have you here today. And as I look at you and as we've talked, I think how fortunate we are to have a person of your experience and your commitment in public service. So thank you for taking on the responsibilities of this very important committee, and I know that we will work together in a bipartisan way to ensure that the critical priorities are adequately funded. You come before us with a budget request of $75.8 billion, amounting to an increase of $4.2 billion in discretionary funding. Your request includes welcome policy proposals that will fund medical breakthroughs, provide affordable child care for working families, and create jobs. The department's budget is symbolic of the President's budget as a whole, in that it calls for investments in research, education, training, infrastructure, all vitally important and interconnected. These investments are necessary not only to the health infrastructure, but are crucial to growing our economy and creating jobs. Throughout my time in Congress, federal funding for the National Institutes of Health has been among my top priorities. Your NIH budget would include an increase of $1 billion, resulting in 1,200 new additional competitive research grants in fiscal year 2016. The NIH budget would make welcomed investments in advanced cancer treatments with a new precision medicine initiative, would increase funding for the Brain Initiative to research the workings of the brain, develop treatments to combat Alzheimer's disease, autism, and other neurological and psychiatric conditions. It would also better the lives of working families and provide children with the building blocks to succeed throughout their lives. I was very pleased to see the President's requested increase of $1.5 billion to expand Head Start to full-year services, and to expand early Head Start programs for infants and toddlers. Now, Mr. Chairman, you reference how do we save money, how do we set priorities. The President has also called for an end of the mindless austerity of sequestration, urging Congress to replace it with more targeted spending cuts, program integrity measures, and the closure of some outdated tax loopholes. The effects of sequestration were immense, are still being felt. Across the government, we see instances where training was postponed, routine investments were put off, and research, especially the critically important research funded in this bill, was abruptly halted. It really was a worst-case scenario for many agencies, such as the NIH, and we have to make sure that it doesn't happen again. As we begin the annual process of crafting a budget resolution, a fiscal blueprint, I know there will be many viewpoints represented in the debate. Many of my colleagues on the other side of the aisle will undoubtedly press on for additional cuts to leave the outdated sequester level caps in place, but I think we all know now how dangerous that is and how we must do everything we can to avoid a repeat of sequestration. We have forged compromise in the past. The Murray-Ryan plan was not perfect, but does provide a path forward for another budget deal. Without such an agreement, our appropriations process is deeply imperiled. Discretionary funding is falling to its lowest level as a percentage of GDP since the Eisenhower administration. So we must act again to ensure reasonable allocations for the important programs and investments funded through the appropriations process, especially those under the jurisdiction of the committee. This bill provides critical federal funding, some of the most important priorities of the American people, groundbreaking health and science research, valuable education programs, job training programs designed to keep this country globally competitive. The dollars we invest in these programs matter. I look forward to your testimony today, Secretary Burwell, and to hear your agency's plan for the coming fiscal year. And I thank you again, Mr. Chairman, and welcome back.
Well, I thank my friend, the gentlelady from New York, and with that, I'd like to recognize my ranking member of this subcommittee, the gentlelady from Connecticut.
Thank you very much, Mr. Chairman, and good morning, Madam Secretary and Mr. Chairman. Congratulations to you, and I look forward to working with you on the efforts that are involved in this subcommittee. Before I begin, let me mention to you, Mr. Chairman, that our colleague, Congresswoman Barbara Lee, is not here this morning and would very much like to be, but I think we know that her mother passed away just a few days ago, and so she is in California tending to personal family and so forth, and I know we send her our thoughts and our prayers. Madam Secretary, welcome to you and your first hearing with this subcommittee. I would like to express my gratitude for the work you and your department do. I know your job can be a thankless one. Everyday successes are overlooked while the mistakes get magnified. I want to highlight two areas of your work. First, your efforts to implement the Affordable Care Act. The Affordable Care Act is helping millions of families across our country. Americans can no longer be denied coverage for pre-existing conditions. Preventive screenings, maternity care, pediatric care are now covered. Women's health has been put on an even footing. Millions of low-income children have health care through CHIP. Insurers can no longer subject families to lifetime caps on coverage. And as we heard from HHS yesterday, the Affordable Care Act is making prescription drugs more affordable for seniors every year. As a result, 9.4 million people on Medicare have saved over $15 billion since 2010. Premiums are down, enrollment is up, nearly 20 million more Americans will have health insurance this year thanks to the Affordable Care Act. This growth in coverage is particularly strong among historically underserved communities like African Americans and lower income Americans. The Congressional Budget Office recently cut its estimate of the cost of expanding coverage, a saving of $140 billion compared to previous estimates. That speaks to the strength of your department's leadership. Second, I want to recognize your measured response to the Ebola outbreak. Instead of bowing to pressure for travel bans and quarantines, you and your colleagues listened to the public health experts. You helped to coordinate a government-wide response that is both turning the tide of infection in West Africa and protecting the public health here at home. The Ebola crisis is a horrific reminder of the need to provide adequate funding for public health institutions under the jurisdiction of this subcommittee, like the CDC, the NIH, and BARDA. Which brings me to the topic of today's hearing, the HHS budget for fiscal year 2016. Programs funded through this budget provide lifelines to millions of Americans. LIHEAP frees working families from the impossible choice of whether to heat their homes or put food on the table. The National Institutes of Health pursue life-saving treatments. A 30-year cancer survivor myself, I know the value of biomedical science. Another crucial HHS program, Head Start, is 50 years old this year, and during that time it has helped to level the playing field for over 30 million low-income preschoolers. As the father of Head Start, Ed Ziegler, put it, my politics is children. And I'm very proud of Ed Ziegler since he is a constituent of the 3rd District of Connecticut. As our population grows, so does the demand for vital programs. Head Start, LIHEAP, the NIH. We need to provide them with the resources that keep pace both with need and with inflation. After years of neglect, your budget request begins to get us back on the right track. I would argue that it does so too slowly, but I recognize that the overall budget must walk a fine line in that regard. There's a lot of good in this request. It substantially increases funding for early childhood through Head Start. It includes $500 million for a multi-agency effort against antibiotic-resistant superbugs. It provides an additional $1 billion for NIH, including funding for a new precision medicine initiative. Current levels of funding across HHS programs remain woefully inadequate. This is largely the result of what in Washington is called sequestration, a disastrous policy of arbitrary cuts and spending caps. Applied to the HHS budget, these cuts and caps are jeopardizing the health of millions of Americans. As is too often the case, low-income families are the hardest hit. Since 2010, after adjusting for inflation, the labor HHS budget has lost almost $20 billion. These cuts mean less money for medical research, less money for public health, and less money for other critical priorities across the labor HHS bill. The inflation-adjusted numbers for the past 5 years tells a dismal story. The Health Resources and Services Administration has seen its discretionary budget cut by a quarter, reducing services for more than 25 million low-income patients who rely on community health centers. Between them, the NIH and the CDC have been cut by more than $4.8 billion. That is a disaster for American public health. We must do better. We need to eliminate the sequester caps once and for all, return to adequate levels of funding to support our nation's health. This budget request starts to do that. We must invest in the NIH, accelerate breakthroughs against diseases like cancer, invest in Head Start to bring benefits of a full-day, year-round service to young children whose need is greatest. We need to invest in public health, strengthen our country in the fight against measles, meningitis, Ebola, and the obesity epidemic. These are examples of critical programs that help to improve the health of our nation. We can and we must find the resources to support them. I do not agree with every proposal in the President's budget. I'm disappointed to see reductions in cancer screening and the graduate training in children's medicine, level funding of the LIHEAP program. But this request does at least show what is possible if we come to our senses, reverse these short-sighted sequester cuts. For the good of all Americans, we need to do this and do it soon. I look forward to your testimony and to our questions.
We've now been joined by the big chairman, as he's affectionately known, so I'll recognize Chairman Rogers for whatever opening remarks he cares to make.
Mr. Chairman, thank you very much for yielding, and congratulations on your very first hearing as chairman of this important subcommittee as we discuss the 016 budget request for HHS. And it's great to see the Secretary join us. Thank you very much. It's a thrill to know that the new Secretary of this huge department of federal government hails from just across the state line from Ashland, Kentucky. Madam Secretary, we're proud of you and wish you well in this new venture. You did a great job over at the budget office and other chores. Undoubtedly, you've taken the reins of this big department during a tumultuous time in our history. The rollout of the President's health care law has been undeniably underwhelming. Our health care costs remain among the highest in the developed world. And despite Obamacare's broad reach and unfathomable price tag, many still remain without access to basic health services, particularly in rural areas. In the face of numerous public health challenges, from the Ebola outbreak abroad to the epidemic of prescription drug abuse here at home, we're facing a budget crunch that requires tough decisions in order to maintain continued investment in life-saving and breakthrough medical research, as well as prevention and treatment initiatives. Unquestionably, much of this crunch is driven by unsustainable growth in mandatory spending, which hamstrings all of us as we seek to make these tough calls. Unfortunately, we've seen no leadership from the White House on your agency to address the billion-dollar elephant in the room, and that's mandatory spending. I want to take a moment to point out in that regard, since I've chaired this committee these 4 years, we've actually cut $165 billion from discretionary spending, while all at the same time the mandatory spending has increased dramatically and continues. When I first came to Congress, entitlements amounted to about a third of the federal spending. Now it's more than 2/3. We only appropriate a third of what federal spending takes place, and that includes, of course, your department. Your challenges are many, and I want to hear how you plan to tackle these and other issues which play so prominent a role in the lives of every American. In particular, I would like to thank you, Madam Secretary, for your attention to the issue of prescription drug abuse, which has been designated by CDC as a national epidemic, and that's especially so in my district and all of East Kentucky. You've personally spoken about the need to address the crisis. I know that many are anxiously awaiting your comments at this year's Prescription Drug Abuse Summit in Atlanta, put together by the organization I formed in my district called Unite to try to stop the problem. Your budget request reflects your commitment to doing your part in a holistic, multi-pronged federal response to this problem. In fact, there's more people dying from prescription drug overdose than automobile accidents in this country, and that's just not acceptable. I've long advocated that treatment and education need to play a critical role in this unique public health challenges. And CDC, SAMHSA, ONC, and AHRQ along with the research branches of your agency, all have a part to play. I'm also pleased that HHS is focusing on leveraging our existing state-run prescription drug monitoring programs with new e-health technologies to make PDMPs more user-friendly for the medical community, and encouraging the development of evidence-based opioid prescribed guidelines to ensure that these powerful addictive medications are being appropriately and safely prescribed. I look forward to hearing more about this $99 million interagency initiative and working with you on this shared goal. We also want to hear about Obamacare. As predicted, since its passage, there have been many hiccups and issues with its implementation. Many of my constituents, who were promised by President Obama that they could keep their plan and keep their doctor, are upset because their plans have been canceled and they no longer have access to their doctor of choice. Premiums have also increased dramatically, and my constituents are paying more for less health insurance coverage. Hospitals in my area are starting to see more and more bad debt because patients can't afford the incredibly high deductibles required by their new health insurance plans. Hospital bills are going unpaid. I fear, unfortunately, that this situation is not unique to my part of the world, in southern and eastern Kentucky, while issues like these continue to unfold around the country. This year's budget requests more money to feed this monster. For the Centers for Medicare and Medicaid Services Program Management, your budget request is $4.2 billion, an increase of $270 million. That kind of growth is just not sustainable. In addition, your request included several added user fees that will wreak havoc on healthcare providers, especially those in rural areas. One example is the administration's proposal to collect a user fee for each purchase of 340B drugs from entities participating in the drug price reduction program. The budget claims this money will be used to enhance the program's integrity efforts, and yet the 015 Omnibus provided $10 million in discretionary funding for that very purpose. Trying to collect this fee from doctors and hospitals that are providing health care services to disadvantaged and rural communities just doesn't make sense. Finally, Madam Secretary, the budget also proposes changes to critical access hospitals that could have a very adverse impact in rural communities. These hospitals provide care in areas with very limited health care access. Many rural people depend on the 24-hour emergency services offered by these facilities. In my district, sparsely populated and full of dangerous mountain roads, we have several critical access hospitals that are doing a great job providing necessary health services to their communities. In many situations, if hospitals were not available, patients in life-threatening situations would have to drive 30 minutes, at least, to the closest medical facility with emergency services. This might mean life or death for someone experiencing a fatal heart attack or stroke. Reducing the rate at which these hospitals are reimbursed and reducing the distance requirement to maintain a critical access hospital designation will have a very detrimental impact on these health care facilities and the people who depend on their services. Madam Secretary, we look forward to hearing your testimony. Thank you for being here. I yield.
Madam Secretary. Thank you. Madam Secretary, your full statement will be entered in the record, and you are now recognized for 5 minutes.
Thank you. Thank you, Chairman Cole, Ranking Member DeLauro, Ranking Member Ms. Lowy, and Chairman Rogers. Thank you all, and to the members of the committee. I want to thank you for this opportunity to discuss the President's budget for the Department of Health and Human Services. I believe firmly that we all share common interests, and therefore we have a number of opportunities to do common good. From preventing and treating substance abuse, as the chairman just mentioned, to advancing the promise of precision medicine, and to build an innovation economy, as well as strengthening the American middle class. The budget before you makes critical investments in healthcare, science, innovation, and human services. It maintains our responsible stewardship of the taxpayer dollar. It strengthens our work together with Congress to prepare our nation for key challenges both at home and abroad. For HHS, it proposes $83.8 billion in discretionary budget authority, $75.8 billion of which is activities that are under this subcommittee. This $4.8 billion increase will allow our department to deliver impact today and lay a strong foundation for tomorrow. It's a fiscally responsible budget, which in tandem with accompanying legislative proposals would save taxpayers a net estimated $250 billion over the next decade. In addition, it is projected to continue slowing the growth in Medicare costs, and it could secure $423 billion in savings as we build a better, smarter health delivery system. In terms of providing all Americans with access to quality, affordable health care, it builds on our historic progress in reducing the number of uninsured and improving coverage for families who already had insurance. We saw a recent example of this progress with the about 11.4 million Americans who have either signed up or re-enrolled in health insurance through the marketplaces in this past open enrollment. Our budget extends CHIP for 4 years. It covers newly eligible adults in the 28 states, plus D.C., which have expanded Medicaid, and it improves access to health care for Native Americans. To support communities throughout the country, including underserved communities, it invests $4.2 billion in health centers and $14.2 billion to bolster our nation's health workforce. It supports more than 15,000 National Health Service Corps clinicians, serving nearly 16 million patients in high-need areas, and it helps with health disparities. With the funding streams ending in 2016, millions stand to lose access to primary care services and providers if we don't take action. To advance our common interest in building a better, smarter, and healthier delivery system, it supports improvements to the way care is delivered, providers are paid, and information is distributed. On an issue for which there is bipartisan agreement, it replaces Medicare's flawed sustainable growth rate formula and supports a long-term policy solution fix to the SGR. The administration supports the type of bipartisan, bicameral efforts that Congress undertook last year. To advance our shared vision for leading the world in science and innovation, it increases funding for NIH by $1 billion to advance biomedical and behavioral research. In addition, it invests $215 million for the Precision Medicine Initiative, a new cross-department effort focused on developing treatments, diagnostics, and prevention strategies that are tailored to an individual's genetic makeup. To further our common interest in providing for Americans the building blocks of healthy and productive lives at every stage of life, this budget outlines an ambitious plan to make affordable, quality childcare available to every working and middle-class family. It supports evidence-based interventions to protect youth in foster care, and it invests to help older Americans live with dignity in their homes and communities. To keep Americans healthy, the budget strengthens our public health infrastructure with $975 million for our domestic and international preparedness, including critical funds to implement the global health security agenda. It also invests in behavioral health services and substance use prevention. Finally, as we look to leave our department stronger, the budget invests in our shared priorities of cracking down on waste, fraud, and abuse. We are also addressing our Medicare appeals backlog, and taking together, we believe this budget advances our broader goals of bringing middle-class economics to the 21st century, providing Americans with those building blocks of healthy and productive lives. As I close, I want to make one final point, and that is that I am personally committed to responding quickly and thoughtfully to the concerns and communications with members of Congress and especially this committee. And since I've been confirmed, I've made it a top priority for our department to do that. And lastly, I also just want to take a moment to thank the employees of HHS. From their work combating Ebola to their compassion assisting those unaccompanied children to the commitment they show every day to help our fellow Americans. I look forward to working closely with you on behalf of the American people. And with that, I look forward to your questions. Thank you.
Well, Madam Chairman, your reputation for responsiveness precedes you, so we know you're certainly as good as your word in that regard. Just for the committee, our chairman and our ranking member have very heavy schedules today, and so I'm going to go ahead and recognize them first so they can ask what other questions they need to pose to you, and can go on their way if they choose to do so. So, Mr. Chairman.
Mr. Chairman, thank you. That's very kind of you to be so considerate. Just as a side note, we're starting our hearing season with gusto. There's 5 hearings today in various subcommittees at which 5 different cabinet secretaries will be appearing. So, but we appreciate you being here, and thank you, Mr. Chairman, for that courtesy. Let me ask you, Madam Secretary, about critical access hospitals. A licensed hospital with a maximum of 25 beds and 24-hour emergency service located in a rural area which meets one of the following criteria: over 35 miles from another hospital, or is over 15 miles from another hospital in mountainous terrain or areas with only secondary roads. I have 7 of those hospitals in my district alone. And in your 016 budget request, you proposed 2 major changes. One, you would prohibit critical access hospital designation for facilities that are less than 10 miles from the nearest hospital. And 2, reduce critical access hospital reimbursements from 101% of reasonable costs to 100% of reasonable costs. The proposed distance change really does not take into consideration, in my judgment, the terrain and the difficult road situation in many rural areas. And Madam Secretary, I know where you lived, and you know there's some mountainous roads and terrain that are formidable in that part of Kentucky and West Virginia. And the economic situation in that region is almost disastrous because of the mine layoffs. I've got 9,000 laid off miners in my district alone. So the economic situation is terrible. To encourage healthcare facilities to take root in these hard-to-serve communities, these critical access hospitals are absolutely vital. You may be aware that we have some very unique health challenges in my area as well. Obesity, a major problem. 31.1% of Kentuckians classified as obese. 66% overweight. Diabetes, unfortunately prevalent, 10% rate among Kentucky adults. Cancer, having a huge impact on Kentucky, where according to CDC and the American Cancer Society, there are 9,600 deaths out of 2,400 incidences per year. These are very troubling statistics, and I believe the problem is magnified in these rural areas across the country, but especially in areas like my district. In the 015 Cromnibus report language, CMS was asked to provide a report about how the proposed 10-mile limit would impact access to services in rural communities, including the analysis and criteria. I haven't seen that report, and I think it's not been yet filed. Are you familiar with it?
Not familiar that this is one of the reports. There's another report that was included in the Cromnibus that was related to language. This one I am not, but I will look into it. We have done some of the analysis around this issue, and so we'll work and follow up on that.
Do you appreciate what I've been saying about the critical need of these hospitals, and that in difficult terrain areas, the 10-mile limit is very important here?
Mr. Chairman, the suite of issues that you described, as you mentioned in your opening remarks, we live in areas that are very close to each other and therefore very similar. And the issues of rural health issues altogether, the team at HHS knows now anything that comes before me, that is one of the first questions. How does it impact rural America?
Would you seek out the report that I mentioned?
I will do that.
See if we can get.
I will. I know that we have looked at the analysis, and what I'm hearing, because the analysis for the nation as a whole is that this would impact, the 10-mile issue would impact only 5% of hospitals, and that what we would be doing is trying to preserve that access to emergency care, those economic issues that you're talking about, making sure that we're using the taxpayers' money as wisely and balancing those issues. The numbers that you are giving me in your district are disproportionate to the numbers I have seen, so I want to follow up on that.
Well, I think that all of that 5% you mentioned is in my district.
That is why when you gave me those numbers, those are not the numbers that I've seen as we reviewed this policy. So want to make sure we understand that. And the broader issues, I just want to recognize across the budget, and whether it's how we're funding CDC, the community health centers, the issues of the Public Health Service Corps, making sure that rural America has access to the needs to health care, and that whether it's behavioral health or primary care or the range of care is something that I consider a very important priority.
And then there's the impact of the hospitals themselves, the economic impact. In my area, many of these hospitals are struggling just to keep the doors open. How would that change in the reimbursement rates affect health care?
So in terms of the broader picture, as we think about these rural hospitals and what is happening in those rural hospitals, in the state of Kentucky, just about 10 days ago, there was a study that was released by Deloitte and the University of Louisville in terms of what the impact has been for both jobs and the GDP in the state. And it said that there would be 40,000 in terms of the number of jobs that will be created from some of the health changes that have occurred. That's the expansion of Medicaid mainly that is causing that, as well as additions to the GDP that would be around $40 billion by 2021. And so that influx also of now having care that is paid for is something that we are seeing both anecdotally and now analytically through that piece of work that has been done in Kentucky in terms of those hospitals getting money. And it's across all over the country where we're seeing, as people have money to pay for insurance, that those hospitals, that's one of the things that we're working on and believe will help some of those hospitals.
Thank you. Briefly and quickly, travel expenses.
Yes, sir.
Local paper recently pointed out that HHS has spent over $31 million on 7,000 first and business class flights for employees from 2009 to 2013. CDC, NIH, FDA, 70 to 80% of the premium tickets were due to the use of medical exceptions to accommodate a special physical need. Those are very large numbers. I'm popping this to you from the clear blue sky.
So,
fair to answer, I guess, but could you tell us what the travel policies are? That's a lot of money for flying.
So I think those numbers are over a period of time, and I know that we have put in more stringent review and
4 years.
requirements.
It's 4 years.
It's a 4-year period, and I think in the past several years we put in place more stringent review and requirements. So we'd want to look and see if that's making a difference to the numbers. The overall is about 3%, and it is in limited circumstances, as you describe, health circumstances or types of things like 14-hour trips. But I think it merits looking at if we are seeing a decline from the more stringent requirements that we've put in place.
Would you check into it?
I will do that.
Mr. Chairman, thank you.
Thank you, Mr. Chairman. The gentlelady from New York is recognized.
Thank you, and again, welcome, Secretary Burwell. I just want to follow up on the hospital. I have questions of the chairman. I'm really quite shocked with those numbers, so I'm glad I live in New York. But on the hospital issue, as we saw with Ebola preparedness and the cases that were identified last year, local hospitals and doctors are on the front line during health emergencies, and Congress provided additional emergency funding for the hospital preparedness program in FY 2015. But hospitals in my community tell me that the funds they have received from the program in previous years are inadequate. So if you could share with us the President's 2016 request, how are we helping the hospitals prepare for and respond to emergencies? Many of them put on extra rooms just to be sure that they were prepared. And this is a very important account. And by the way, I'm delighted that you mentioned community health centers, because they are providing such important services, certainly in my communities. So if you can address that account, that would be very helpful.
So the issue of hospital preparedness specifically, I think, is nested in the broader issue of our preparedness as a nation when we have issues like we did with Ebola. And it is across the system that we need to be prepared, and that is both in terms of the state and local public health systems that are in place, as well as those hospitals that are in place. And so funding across all of those pieces is important to make sure that the system works, because where there's a fault in one place, I'm not sure everyone here read, but many of you may have read that this morning I, of course, had a person under investigation notice in Bellevue Hospital in New York in terms of we are still tracking people that come and making sure on the Ebola front. So it is across that whole spectrum. With the money, and thank you, first, let me express appreciation with the $2.7 billion that we received to work on Ebola. Appreciate it. Are moving those monies quickly. And as you probably know, on Friday we announced the funding announcement so that requests can come in from states to do a portion of that funding that would occur to the hospitals. So we are using both those monies as well as the monies in the 16 budget proposal to make sure that we get to the levels of preparedness that we need to as a nation. And one of the things in terms of that preparedness is, and we were directed by the Congress, which we agree with, is to put in place a regional strategy for Ebola and making sure that we have a set number of hospitals that are prepared for the most extreme situation, a number of hospitals that can then support that effort and also do care, and then what we would consider hospitals that analyze and make sure a patient is determined whether they should be somewhere. And then there's the front line, making sure that that frontline hospital knows this is something suspicious, I need to get it to someone who can handle it. And so there's a strategic overlay and then the financial overlay in terms of how we're trying to address the issue.
I'd appreciate continuing to work with you on that issue, because, as you know, many of the local hospitals don't know what a person is bringing in when they come in with 105 fever, and so they're looking at decontamination units, et cetera. So I know we agree on both sides of the aisle that we don't want to be wasting money, but you need to invest in areas where the funding is very critical. I want to mention one other area, because we've been doing a lot of work with autism, ranging from research at the NIH to workforce training programs at HRSA. I'd be interested if you share with us how your FY 2016 budget requests would help the increasing number of families who are living with autism. What we are seeing is some very exciting investments in work placement for these young people, not so young, as really they age out of their school opportunities. So I'm really interested in just a brief overview of what you're doing.
I think it's in the two areas that you've articulated. One is in the research space, and as you mentioned in your opening statement, the issue of the BRAIN initiative and the investments we're making in research, where we can understand better the issues around autism, both cause and how we can work through it when there are cases. And so the research is a big part of it, and that's a part of the BRAIN initiative. The other place in the department where this sits is in the Administration for Community Living, and making sure that we are working with our colleagues in some cases the Department of Labor, but also as we think about how people have community-based living and working on those issues there. So those are the two main areas that the funding in the budget addresses this issue.
Thank you, Mr. Chairman. And I just want to say to the big chairman and the very big chairman, I know we all look forward to working with you and with the secretary. We all want to cut out waste for programs that are not really working, because your responsibilities are so very important that you don't want to cut in areas that are really critical. And this is why the sequestration issue, and I know the big chairman and I have had many conversations on this, it just doesn't make any sense. So I hope as we move forward we can address the basic funding issues that would give you the opportunity to continue to improve lives. Thank you.
Thank you. Let me pick up from there. I can. That's actually a very nice lead-in, which is not unusual for my good friend from New York, and I see these things in a similar fashion. As I suggested in my opening remarks, I have concerns that your budget is based on financial tax increases and fees and that are unlikely to pass and actually become law. So I think your number is probably a little bit higher than we're going to end up with in this committee. Given that fact, or given that possibility, and again, it could always change if there's a larger deal that involved the president and the congressional leadership, but absent that, what would be, if we had to operate on roughly the same amount of money we had last year, how would you prioritize that? What are the most important things from your perspective that you'd really like to see accomplished?
So, Mr. Chairman, when we put together the budget, as we put together a budget, and I am now a piece of it. I used to be in a seat that brought all the pieces together. But what we've tried to do is make those choices and articulate where we believe the choices should be made. And those are choices that I believe, we all need to discuss. But those are important choices. And one of the reasons that I think they are extremely important choices is it is a cap, but it is sequester. It is a policy that I think many did not expect to be in place. And whether you did or you didn't, I actually think we should put that aside, but actually put through and view it from the lens of what is the actual impact. And when we think about the levels, when you say about the choices and what happens at these lower levels, I think it is important to hearken back to what happened in 13. When we were, for a period of time, at what we would call a sequester level. And let me just give two examples. One is at NIH. During that time at NIH, we had the lowest number of grants that we were doing for project research that we had in a decade's time. In Head Start, 57,000 children lost their Head Start. And so I understand that these are tough choices. I understand why this is not, in terms of the jurisdiction, it goes well beyond this committee to many other committees as well. But I just think we have to, part of what we try to do in our budget is be responsible about saying, and as a percentage of GDP, when you think about our discretionary spending, and we can have the mandatory conversation that the chairman raised, I'm not sure, we want to do that here, but that we do need to recognize in terms of the investments we need to make as a nation. And let's just look at the year in review. When Ebola happened, what were the expectations of the executive branch and the federal government? And whether, with regard to the issue of when the children came, how do we take care of those children in an appropriate fashion in terms of the unaccompanied children? Measles right now. Right now we read in the newspapers the issues of the superbug and the question of, are we, aggressive enough about that? And is the federal government aggressive enough on measles? Those are state responsibilities. So my answer to the question is, we believe that we have put forward what we believe are the right choices. And those choices extend across and beyond committee jurisdiction, and I know that. But those are the choices, and they are tough choices. They are, and we know that some will be disagreed with, just as, the critical access issue we just discussed, or, what I heard from Ranking Member Lowy is, perhaps you didn't put enough in the hospital. And so we have throughout made choices, and in the discretionary, over $750 million worth of cuts.
Well, again, I don't disagree with that, but just for the record, this isn't a policy, it's the law. It's a law that Congress passed. It's a law that the president signed. And again, absent a larger agreement, we'll be living within the law, I suspect. So I think we're going to have to make those choices, and I look forward to working with you as we go forward. Let me quickly move to one other matter, because I can't enforce the 5-minute rule if I don't keep it myself. I know you're familiar with the Weldon Amendment, which has been carried in labor LHHS bill since fiscal year 2005. The amendment prohibits federal funding prohibits funding to any federal, state, or local government that discriminates against a health plan for refusing to cover abortion. Obama administration has issued regulations designating the HHS Office of Civil Rights to enforce the Weldon Amendment by receiving complaints and violations. I understand, I've been informed, perhaps misinformed, but informed that the state of California, recipient of funds under the bill, recently began requiring all health plans sold within California to provide coverage for abortion on demand through all 9 months of pregnancy. It's a clear violation of the Weldon Amendment. However, 6 months after the mandate was issued, your Office of Civil Rights has failed to take corrective action. The mandate went into place immediately in August of 2014, so real harm is actually occurring now. Complaints have been filed by several entities, including a number of evangelical churches that oppose abortion and are currently being compelled to fund it through their health insurance. So time is the essence. Could you tell us where we stand in this matter and when your Office of Civil Rights Compliance intends to act?
With regard to the implementation of the Weldon Amendment, it is something that we take very seriously, and the complaints came in and we opened the investigation with the Office of Civil Rights. We are moving to do that investigation expeditiously. With regard to my ability to say and tell the Office of Civil Rights when to finish the investigation, that's something we want to let the investigation run its course so we can use its results. And so we are working expeditiously. The Office of Civil Rights knows this is an important issue, as you have said, and that time is of the essence.
So the investigation is underway right now?
It is, and yes, sir, it is. Right now, we heard from organizations, and when we heard from organizations with regard to the issues that you've raised, we opened an investigation.
Well, thank you very much, Madam Secretary, and we will be following up with you on that to make sure that investigation does get carried through. With that, sorry I ran over a little bit, but I recognize my good friend from Connecticut, the ranking member.
Thank you very much, Mr. Chairman. And just for the record, I might just note that since 2010, after adjusting for inflation, the labor HHS budget has lost only almost $20 billion. And with regard to the allocation affecting labor HHS, I've stated this many times in the past that I believe that it really is, labor HHS has taken one of the biggest hits of any of the appropriation subcommittees, and we need to remedy that. Madam Secretary, Bureau of Labor Statistics released data that show that hospital prices are declining over the past 12 months. The largest decline in prices comes in the Medicare program. Score 1 for single payer. But prices paid by private insurers grew by only 1.6%, which is substantially lower than the 6 to 7% annual increases that we used to accept as the cost of doing business. How much of the decline in healthcare costs is attributable to the Affordable Care Act? Can you talk about some of the Affordable Care Act's cost containment measures that have led to such a dramatic change in the healthcare cost curve?
So with regard to the government pay part of this, the portion of it, there were changes that were part of the act that we moved to implement, and there are types of things that we will continue to work on. As we know, in 2009, when CBO was predicting Medicare expenditures over the period, we know that we're $116 billion less than we have been, than we would have been on that trajectory. And those are changes, attributable both to the market and to changes that were put in place. With regard to the market, you also mentioned the actual broader marketplace beyond Medicare. And one of the things that I think is happening is the issue of competition with regard to how that puts pressure on these issues. And we know that there were 25% more issuers that came into the marketplace, and in terms of that price pressure that we see, I think we are starting to make progress, and we've seen some progress. We have seen through Medicare some of our efforts on patient safety. So we've seen a 17% reduction in patient harms through efforts that we've partnered with physicians on testing ways that you can reduce harms. Those are infections and falls in the hospital. And those kinds of things reduce, and then not only lives do they save, but it is savings. And so this is all part of the broader part of, when we think about that issue of the Affordable Care Act, quality, access, and affordability, reforming our system so that we deliver better quality at a lower price has been a priority. We've made some progress, but I believe that we can make more progress. And that is an announcement that we made recently for the first time, we have set the goal that in Medicare by 2016, there will be 30% of all payments will be in an alternative payment form so that we can continue to build on those kinds of savings, as well as quality.
Just a couple of points, and I will just mention medical loss ratio, which has really worked to make sure insurance companies are spending 80% of their collections on the premiums, and that has resulted in billions of dollars in rebates to the American families. The pay for
2.8.
value effort and shifting that cost in Medicare for value as opposed to simply paying for volume of services. Just briefly, because I'd love to get another question, and the department plans to make 50% of payments through alternative payment models by 2018.
That is part of the delivery system reform. We'll get to 30% by 2016,
okay.
and then 50%. At that point, people will be doing the alternative payment models, paying for value, not volume.
So we can conclude that if the ACA continues to constrain the growth of health care costs, won't that wipe out a significant portion of the projected future deficits?
We want to continue both through the implementation of delivery system reform and the proposals we have to reduce that spending in the entitlement space.
Thank you. I'd like to move to Head Start, and I'll do this quickly. I just want to say this because I think it's important. 1912, a teacher in a one-room schoolhouse in Texas made a decision that would ultimately affect the lives of over 30 million American children. She allowed a 4-year-old boy to join her class, jump-starting his education by a year at a time when the concept of preschool learning was virtually non-existent. That boy was Lyndon B. Johnson, and he would go on to be a teacher, President of the United States, and Head Start was established under his presidency 50 years ago this spring. 8-week summer camp, a robust year-round program that serves 1 million children every year in the U.S., state, and territory. So congratulations on 50th the anniversary. But can you tell us briefly about the expansion of full-day, full services for Head Start and Early Head Start and the gains you expect to see?
So in this budget, I'll just focus on 3 things. One is that expansion of full day, that expansion of full year, because we know that that's an important way to maintain the gains. And then the second thing is the quality implementation, and those have been conversations, making sure that we have standards. Those 2 steps will help us improve quality, but also making sure that those Head Start providers in the program are meeting quality standards.
Thank you, Mr. Chairman.
Thank you. The gentleman from Idaho is recognized.
Thank you, Mr. Chairman, and congratulations on taking charge of the chairmanship of this committee and for your first hearing. And
Can I just say for the record, since you suggested me for this job, I'm glad you were brave enough to then join us on the committee.
I felt if I recommended you for the job that I should be willing to suffer with you. I don't mean that. This is a very important committee. Ralph regularly used to call it the People's Committee because it affects so many people, and programs in it are very important. But congratulations to you, and welcome to your first hearing before this most friendly subcommittee. I read your testimony last night, and I actually agree with an awful lot of what's said in there and a lot of the programs that you've emphasized and put the resources into. The problem is, as the chairman has said, it's dollars and how many dollars we're going to have to spend and stuff. And I agree with my colleagues here who have suggested that sequestration, and you have suggested that sequestration is going to be devastating. It really is going to be devastating, and I wish the President hadn't proposed it as the hammer on the Supercommittee that was ultimately adopted. It was never going to happen. It was passed, and it was so ugly that we were never going to do it, but yet here we are. The problem is the President proposes doing away with sequestration and blowing the numbers off in his budget, and doing it with tax increases and fee increases and everything, and very little, if anything, on the mandatory side of the program, which is driving our budget deficit. And right now, while we applaud ourselves and pat ourselves on the back about the fact that the budget deficit is down by 2/3, essentially, from the high, it's still $500 billion. And if you look at the $18 trillion in debt and the interest paid on that at historical interest rates, the interest we pay on the national debt would outspend defense spending, labor age spending, and much of the rest of the discretionary spending. So it's still important we focus on the fact that we're in debt and that we've got to address that. And that's what sequestration is about, not the best way to do it. And I hope they come up with a budget deal to ultimately deal with it. But having said that, a couple of dental questions. You might guess that dental questions would come from the dentist on the committee. The CDC has said that one of the top 10 public health achievements of the 20th century is water fluoridation. This marks the 70th anniversary of the community water fluoridation programs. What plans does HHS have to acknowledge this 70-year milestone and educate communities about the preventative health benefits of community water fluoridation? And when will HHS be finalizing its recommendation to set the level for optimally fluoridated water at 0.7 parts per million? Dentistry supported the proposed change, but it has been waiting for 4 years to see the final recommendation.
This is an issue that I think the issue of the recommendation and where we go with regard to the number is something that I expect in the relatively near future that we will come out with. A question of the anniversary, I will admit, is one that I will go back to CDC, and I'm just very happy that we now have a Surgeon General who is a part of a great voice for us in a nation to do this type of thing and make sure the nation knows. He's been terrific on measles, he's been helpful on flu, having that voice with the American people as a physician, and so now I need to add this fluoride anniversary to the list of things to find out.
Currently, the federal marketplace, in the federal marketplace, consumers must purchase a medical plan before purchasing any dental plan. This requirement prohibits adults from purchasing dental plans, including Medicare-eligible seniors, and also creates a challenging purchasing experience for consumers who want one-stop shopping. Will HHS consider allowing direct purchase of dental plans so that consumers are able to purchase dental benefits within the marketplace if they desire?
That is one in terms of considering the standalone purchase is the question I think that you're asking, and that is something I'm happy to go back and look into in terms of what is whether it's what is the limitation currently in terms of why it doesn't happen.
I think it would take, from everyone I've talked to, is a technical change that could happen within HHS. It wouldn't take statute or anything Congress to do, but I think that it could be done by your department. As you know, HHS has mandated the replacement of the ICD-9 CM code set currently used by medical coders and billers to report diagnosis and procedures with the new ICD-10 code effective October 1st, 2015. This will be a significant change in the way coding is done, and I've heard from physicians in Idaho and frankly across the country that have small practices that the cost and overall impact of it that it will have on them could actually lead to them shutting down their doors. Given that Congress has already delayed implementation, I wonder what your thoughts are on either delaying or allowing a phase-in period after the October 1st deadline.
So with regard to, we have delayed, as you reflected, and believe that we would be ready by the October 15th deadline in terms of October 2015 deadline this year. And we've done testing, and we are doing testing. And so if there are providers that have concerns, if you can help us understand, because we want to continue to do that testing in terms of making sure that people are ready. The value and the benefit when we get to more simplified coding, which I think is something that is beneficial across the system to some of the costs that we were talking about. That's why we want to go ahead and move forward with it, but we're trying to do it in a way that we make sure we listen and understand, which is a part of why we're doing the testing. If there are specific examples that you're hearing about, we'd like to know about them and hear so that we can work with folks about that.
I look forward to working with you on it. Thank you.
Mm-hmm.
Thank you. I recognize the gentlelady from California, my good friend, Ms. Robile Island.
Thank you, Mr. Chairman.
And can I say I was at the CDC recently and saw the building named after your father, so it was pretty remarkable.
Okay, thank you.
Thank you.
Madam Secretary, in today's increasingly diverse population, HRSA's Title VII health professions training programs have really been an invaluable tool in creating a pipeline of minority primary care professionals who overwhelmingly return to practice in diverse and underserved areas. So I truly want to commend the administration for its support of the Minority Centers of Excellence and Nursing Workforce Diversity programs, and for allocating the $14 million for a new program to build on that experience gained from the Health Careers Opportunity Program. However, I am disappointed with your proposal to eliminate the Area Health Education Centers program, which has successfully recruited students and provided training opportunities for residents and practitioners both in rural and urban underserved areas. This program, as you know, has been repeatedly cited by HRSA as exceeding the agency's goals and objectives. Therefore, I would, if you could, explain why the AHEC program was not funded despite its long successful history, and what funding sources are you referencing in your budget justification as being able to support ongoing AHEC activities. And I have, I'll give you the other two questions. I have related questions so you can answer all at once. Also, how will the new workforce diversity program differ from the old HCOP program, and will the new program continue to target minority and disadvantaged high school and college students, and how will you ensure that its results in similar increases in the numbers of minority health professions?
So with regard to the first issue in the program, I think one of the things that we're trying to do is make sure that in this important time, as you reflected, that we do get diverse workforce into the communities. And that's about the training and then getting them there into the communities. And I think one of the most important anchors of making that concept, which we agree upon, become a reality is actually the National Health Service Corps. Because when we look at those numbers and you see that expansion that we're proposing in our budget, 30% of all of the National Health Service Corps are actually minorities, and I'm sure many of you, because there are a number of physicians present and folks who focus on this issue, only 10% of the population. So we overrepresent, and by working and adding there, we believe that's an important step. With regard to that specific program, what we believe is that it has been an important program, but one of the things as we set up the program, we asked the grantees and others to have sustainability plans so that this would be a program you got up and running. With regard to the second issue, the issue of the HCOP and that question of who will be trained. One of the things that we're trying to do is make sure that we are getting those individuals who are both interested in clinical practice as well as research. We're doing this in the piece you're talking about, but also as we look at NIH. There are individuals who have expressed that interest, who are, so we are focusing on the people at that level who have expressed that interest, want to be scientists, want to be doctors and physicians, but we lose along the way. And so we are putting our emphasis in our budget on those individuals that we know are in, so we don't lose those people who are already there versus focusing on some of the very early years they're in the program. So I think there is overlap, but some of the earliest years, I think we believe that if we can get more people who are interested in starting to do the training in the space to stay in, that we get our numbers up and more people into the communities more quickly, number one, and we create the role models that help create pull later on. So it is overall, in terms of that's how we're trying to think about the spending of the dollars in a priority area that we're focused on.
Okay, so just so that I understand, but you still need that pipeline. And in other words, I understand what the end game is, but how do you, what is in the program that will continue to feed that pipeline so that you will have those?
I think right now what we are focusing on is the point at which there are people in the pipeline in terms of how we are putting emphasis with our dollars.
But I guess what my question is, that's fine in the short term for the next year, maybe 2 year, but as we go down, to 5-10 years from now, how is that pipeline going to be fed?
I think the question of in elementary school and children's exposure in terms of diverse children and other children, in terms of STEM issues across the board, in terms of the place where I think we believe that there are issues that we see happening with regard to minorities, is at that level when they become engaged and may not have the support that they need to stay engaged in that way, and that's where we're going to emphasize in terms of what the budget does at this point.
I see my
Okay, gentleman from Arkansas, my good friend is recognized.
Thank you, Mr. Chairman, and I too want to join the chorus of people congratulating you on your chairmanship and the skill at which you execute your duties as chairman of this very important subcommittee. And I want to welcome my friend, the secretary, here today. I would expect that her background over at budget is probably an invaluable asset when considering the matters that we're talking about here today. The overall chairman, to no surprise, talked a little bit about the problems combating drug addiction. And Madam Secretary, you're well aware of
state that I represent, part of the state that I represent, and the fact that drug addiction, particularly prescription drug abuse, is a major issue facing our country, and I'm glad that we are recognizing that it is of such major proportions that that we have to put a higher priority on it. As a matter of fact, in the couple of hours that we are going to be in this room today, on average, 10 people are going to die as a result of some kind of a drug overdose. Nearly 7,000 a day are going to be treated in ERs around the country. There's no question, when I talk to my job creators back in my district, they talk to me about the fact that they have jobs available, but they have very difficult times finding people who can do something as simple as pass a drug screen for an employment opportunity. So, I mean, without belaboring the point, we don't need to have a debate about that. That debate has taken place. Last September, nearly 50 of my colleagues and I sent a letter to you and the administrator of SAMHSA calling for a modernization of our government's response to this crisis. We didn't receive a response initially, and I'm glad in your testimony you talk about responding to members of Congress as a high priority of yours. But our Cromnibus included report language asking SAMHSA to update all of its professional education and training programs for opioid treatments and office-based treatment programs. Do you know at this stage of the game what steps have been taken to fulfill this congressional request in the Cromnibus?
I will have to look and see in terms of where we are exactly, but it is a major part of the three-part strategy that we are pursuing in terms of this issue of opioids, heroin, and overdose, in terms of the first part being about prescribing, in terms of the place where we need to focus, as Chairman Rogers mentioned, in terms of the national, the state-by-state plans. This is an important part of giving that instruction on prescribing. And so we're moving forward on it exactly where we are in the process related to the exact language of the Cromnibus. I'll want to get back to you. But it is a very important part of the three-part strategy that we are pursuing in this space, which is first, the issue of prescribing, second, the issue, as you mentioned, of things like naloxone and how we have access to those, and then third, the treatment issue, or the three places that we are working.
Do we have any other real barriers to our ability as a nation to elevate the discussion, to recognize its significance, from loss of life to productivity? It's I cannot underemphasize or overemphasize the impact that it's having, and I mean, are there other barriers that this panel, that this Congress needs to know about?
So some of the things we've mentioned in terms of the budget, and I think the chairman spoke to in terms of the funding issues, and I think those are articulated. I think the other thing, and I just spent time with the governors this weekend when they were in town on this issue specifically, because one of the things that we have to do is we have to have tracking mechanisms with regard to the prescribing. We can teach people about the prescribing, but one of the things that's happening, and to add to your statistics, in 2012 to 13, there were 259 million prescriptions for opioids. And I think you all know the population of the United States, so you understand what that means in terms of, so getting that prescribing, tracking that prescribing and the filling of those prescriptions. That is a place that we've seen progress in places like Florida and some other states that are taking action. And that's a place we're going to need to work with the states and making sure there's interoperability with the states. When the chairman mentioned the Office of National Coordinator of Electronic Medical Records. So those are some of the critical path issues. We need people to know about the prescribing. We need them to abide by that. And then we need to do the quality tracking. And we need to be willing to take the steps in terms of payers and others when people aren't abiding by. And we need partnerships with the private sector. CVS tracks within their own system, but you can go to Walmart, Walgreens, or others. And so those are some of the critical things we need to do.
Well, even in our own state, there's been a major discussion, and I'm sure this is happening in every state, but particularly in Arkansas, the fact that it's a small state with a limited budget, and now we've got so much of this phenomenon happening. It's crowding our prisons. We're putting people behind bars and an extremely high cost, while other violent type criminals are competing for that type of bed space. And so somehow, some way, our nation has to wrap its arms around this increasing phenomenon that's directly affecting our economy. I see my time is out, and I'll come back later in the next round. Thank you, Mr. Chairman.
Thank you. Friend, the gentleman from Tennessee is recognized.
Thank you, Mr. Chairman, and I want to join in the praise and thankfulness for you taking chairmanship of this most important subcommittee. This is my third term in Congress, my second term on this most important subcommittee, and I appreciate serving with you in your chairmanship, sir. Madam Secretary, good morning.
Good morning.
I want to thank you as well for stepping up. This is an arduous task that you have to chair HHS, and I also want to thank you for your phone call yesterday and for your civility. And we all have a difficult role in governing this great nation, and I want to thank you for being here today. I'm going to ask some questions about Obamacare and then RAC audits, but in candidness, I believe Obamacare is inherently flawed. I thought it was flawed from the beginning. I was not in Congress when it was passed. It's had a lot of frailties, and I come to the debate after having seen this now in my third term in Congress, just so frustrated with this issue. So I want to let you know that on the onset as I ask you these questions. And I know you've inherited this role, and I thank you for stepping up and taking that. Last March, your predecessor was before us in this committee, and I asked her questions. And she testified before this panel that the administration would not delay the individual mandate or any of its penalties. Yet less than 2 weeks later, the enrollment deadline was extended. Last week, HHS announced that it had sent 800,000 people incorrect tax forms. We learned yesterday that's led to approximately 50,000 inaccurate tax returns filed by Americans on which the Treasury Department has announced it will not act. Separately, HHS announced that you would open a special enrollment period in order for people to avoid paying penalties for missing all the previous deadlines. Madam Secretary, my first question, and it's a two-part question, is what authority does the administration have to set its own policy each time Obamacare is implemented incorrectly? And as a follow-up to that, I would specifically like to know what authority you believe your department has to declare a new enrollment period and set arbitrary deadlines.
With regard to the issue of, I'll address the most recent special enrollment period. Special enrollment periods occur for people when they have life-changing events and they are able to enter in the system. You know, it is based, we have a marketplace-based system, and the marketplace is based on private insurance. And so insurers actually have periods when you have a life change, when something happens that is unique, that you can come in not during their set period. And so that's, with regard to the issue of special enrollment periods, that's what we've done. With the one that you're referring to specifically, for those individuals who did not recognize that there would be a fee, that they did not understand, that they did not, this first time through, what we have said is for those individuals that there will be a special enrollment period for that limited group of people. And that's what this particular one that you just referenced that we just did is about.
Okay, thank you. Madam Secretary, I'd like to ask you some questions about your plans regarding recovery audit contractors, the RAC audits.
Yes.
These have wreaked havoc on Medicare reimbursement processes. I understand you're considering establishing a fee for claims appeals to raise revenue and discourage appeals in light of the huge backlog which remains. I cannot see that as anything more than encouraging my constituents to succumb to a broken RAC system. What plans do you have to address the underlying problem of the number of audits resulting in the denial of claims that should have actually been paid?
So with regard to the, this issue, when I came in, it is an issue and there is a large backlog. So put together an approach to working through that backlog as quickly as possible and are very appreciative that there is bipartisan, bicameral engagement in the issue with us, because I think it's going to take us working together to get through. 3 things we need to do to get those numbers down. the first thing that we need to do is where there are administrative things that we can do at CMS in terms of making that go more quickly, or where appropriate, settling through with providers, that we do that. The second thing is we have asked for the funding to help us get more specialists. This happens through the Office of Medicare Appeals and hearings and appeals. And so this is a body that is part of HHS, but there are specialized appeal judges that have to hear these. And so we need the help to work through the backlog. That's item 2 in terms of getting rid of this backlog. Number 3 is we actually are asking for legislative changes from you all to try and make sure that we discourage. A couple things about the fee. 1, never on a beneficiary. Number 2, if you win your appeal, the fee comes back. Because what we're seeing is in this appeal process, because it's easy and it's simple, part of the reason we've had it skyrocket is there's not a cost. If I think I might possibly be able to get the money, I'm going to appeal, because there's the time issue, but what do I, in terms of that? And so that's why we believe it is something that could help us with the overall issue.
Thank you very much, Madam Chairman, and I yield back.
Thank you. I thank the gentleman, and now move on to the gentleman from Maryland, probably the one real expert we have on this committee that knows something about what he's talking about. So,
Thank you,
Dr.
Mr. Chairman,
Harris.
Thank you, Madam Secretary, for coming before the committee, and welcome. First, a couple of questions that are just very short because my time is limited. With reference to the Independent Payment Advisory Board, or IPAB, the budget document says that this is one of the mechanisms that is going to reduce long-term drivers of Medicare costs. Do you intend to appoint members to that board this year?
If the Congress makes recommendations, we would welcome those.
You don't need congressional recommendations. Do you intend to? The law, the ACA, very specifically says you have the authority to appoint the board. Do you intend to appoint the board?
It says in consultation with the Congress, and that's the part we would like to have.
Just to follow up to Mr. Simpson's question on ICD-10, since the CMS website says that you can run ICD-9 and ICD-10 parallel, pretty clearly says it can be done, would you consider creating a hardship exemption for ICD-10 for physicians whose practices just can't afford to convert to ICD-10?
Would want to understand how that would actually work in terms of those physicians, if that's something that, happy to understand and take a look at that question. I think we believe everyone should switch and that people are ready.
I fully understand how the government thinks everybody should switch to the regulatory scheme proposed by the government. I am telling you this is one of the largest concerns of small physician groups, the ones we want to help, the small rural physicians who can't afford to convert to ICD-10. The CMS website clearly says they can be parallel. I would hope you'd be opening to creating a hardship exemption. Maryland's health exchange was a disaster. They're now in court. They're going to try to recover money from contractors. I just want to ask you, Madam Secretary, if Maryland recovers money from contractors, are you going to seek the return of that money to HHS?
With regard to the issue of how these contracts were done, it is a matter of when the contracts that we had with the states, in terms of the agreements we had with the states, depending on why the money comes back and what was done wrong, is the answer to that. Where we have the ability to, in terms of our relationship, sometimes those actually have to do with the contract with the state, not with their relationship in terms of fulfilling their commitments to the federal government. Where there are cases where that can happen, that's something we'd like to understand.
Thanks.
And our IG is working on it.
The overall budget increase proposed was an increase of 6% to HHS. That's right, round numbers.
Yes.
Why is NIH only 3%? I mean, if the administration always talks about the importance of research and all, why actually would you disproportionately not raise the primary driver of basic medical research in the country? I mean, why would you choose to expand other parts of HHS and not to expand NIH at the same extent?
So with regard to the increases across the department, we believe that a $1 billion increase for NIH is a healthy increase. And NIH, in terms of what it's seen over the period of time, has been different in different areas. Some of the increases that are larger, we just actually spoke about one of the ones with your colleague in terms of some of our program integrity efforts have larger increases in percentage terms than, say, NIH does. Another area is we're working very hard to implement the Congress, the legislation that you all gave us with regard to FSMA and food health safety, and so there are increases that are larger in other parts of the department.
So a decision was made to not prioritize NIH for their share of the 6% increase. I mean, again, it's the numbers are the numbers. The administration says we need 6% more for HHS, but you only need 3% more for NIH.
With regard to how we put a budget together, I think area by area and operating division by operating division, we determine the needs, and then we have to make choices and trade-offs in terms of how we do that. In terms of taking a percentage and giving everybody a percentage increase, that's actually not how we put our budget together. What we did was work through, as I said, whether it's particular needs that we have in program integrity or the implementation of laws that we have, there are places where we need larger increases.
I fully understand the prioritization. I'm a little disappointed that the administration, and let's face it, this is kind of a make-believe budget because it doesn't accept the budget caps that are in current law. So at least in your make-believe budget, I would have hoped that you would give the NIH the average increase in HHS. With regards to the Strategic National Stockpile, can you assure the committee that your fiscal FY16 budget request for the SNS will be sufficient for procurement of both newer medical countermeasures and for the replenishment of the existing stockpiled medical countermeasures?
We have proposed the budget that we believe will meet those needs as well as what we believe we can adequately spend in terms of making sure we're managing the taxpayers' money well.
And will that be enough to procure the 75 million doses of anthrax vaccine that would be needed?
With regard to the specific of that particular procurement, that's something I want to get back to you on.
I'd appreciate that. Thank you, Mr. Chairman. I yield back.
Just following in order, I'm going to skip down actually to Mr. Regal, who was here at the beginning of the hearing, and then we'll come back.
Thank you, Mr. Chairman. And Secretary Burwell, thank you for being here today. It's a pleasure. I want to call your attention to page 16 of your testimony, which I read carefully. And let me just highlight here, between fiscal year 2009 and 14, the number of appeals received by the Office of Medicare Hearings and Appeals has increased by more than 1,300%. And I read carefully where you're going with your response. And I say this in a constructive way, but it seemed to me like a circular loop. The first action was to take administrative action. And the second part was to request new resources. And then third was to implement new strategies. So the strategy is to implement a new strategy. And I'm going to give you just a moment to respond, but then the third part says propose legislative reforms that provide additional funding. So it was taking administrative actions, finding new resources, which are funding, and then to implement a new strategy. The strategy was to implement a new strategy, and then the third one was additional funding. So I felt like I ended up right where I started, and there was no explanation at all that I saw, perhaps I missed it, as to what was causing it, nor was there a satisfactory answer as to what you'll be doing about it.
So with regard, I apologize if I used the word strategy policies, and the policies that your colleague referred to are some of the types of policies that we believe are important. We think in terms of what is happening is that, first of all, we have a backlog, and part of what we need to do is work through the existing backlog. And in terms of administrative actions, and whether that's settlements or additional funding to work through that backlog, it's very important. As we think through the question of how to deter those kinds of numbers in the future, what we do think is it's important to put in place certain types of deterrence, and also I think we believe that there are places where the amounts and what people are appealing should be changed.
Okay. I guess you're somewhat answering the question on what's driving this, the causal factors that led. I mean, it was a stunning increase in the number of appeals, and I'm sure many of them need to be paid, and then some of them are probably fraudulent, of course. But help us to understand, has the department, as the agency, have you been able to understand why the sharp increase?
I think we think that some of the reason that there's been a sharp increase is because there actually has been the development of a number of people who see this as an opportunity and an economic opportunity to help providers appeal. And so one of the things, and that's why we want to do some of these policy changes, is to put in place deterrence to that.
Deterrence from the third parties being able to engage in that, or deterrence?
Frivolous appeal.
There you go. Well, we're in complete agreement on that.
Frivolous appeal is all we're trying to get at, which is why in the proposal we have, if you win, you don't pay. So what we're trying to do is get to a place where, you know, appeals are important. We understand that. Do we get it right 100% of the time? When you look at the numbers, actually, they're quite, the appeals are actually small relative to the number of transactions in Medicare. It's still relatively small. But what we want to get at are the frivolous appeals.
Okay. I'm just going to make a comment here at the end, and that is just as it relates to what Chairman Rogers said, and I was very encouraged to hear him say this. He was speaking about the failure, really, of us as a nation, all branches, although I'm proud of what we've done as House Republicans on this matter, but the failure to address mandatory spending. There's going to be compression on the rest of the budget, discretionary part, into perpetuity because of the sharp increase in the number of seniors over the next 10 years. And I really haven't seen anything from the administration on this. And I considered it a real special opportunity, if you will, to meet with the President just briefly on this. And he said, Scott, what's on your mind? I said, Mr. President, I said, I'm just deeply concerned about we have not, as a nation, and I haven't seen from the administration enough leadership on this this topic, because the math, it needs to be faced by the American people and all of us, that we've got to come up with meaningful reforms on mandatory spending. So I would implore you and your colleagues to lead in this. It's something that's got to be done for us to have a bright future for our children and grandchildren, and all of us, actually.
I think it is an issue of importance, and we look forward to hearing the response to our $450 billion worth of cuts that are represented in the HHS budget, specifically on the mandatory side. And while one can say we should do more, I think I hear that as your point. I guess I would say
the math leads me to this conclusion. That's why I bring it up.
And I think we have $450 billion worth of changes on the table as part of our overarching budget, and the question is we have an approach to work on those issues, and I think we look forward to hearing how people think about those.
Well, I appreciate the spirit in which that's offered, and I'll learn more about it. It's just my experience has been, to this point, that the administration has just not really led in this area, and just as a fellow American, I'm just asking that take place. But I appreciate your testimony today and your service at the agency. Thank you.
Thank you. Thank you.
I yield back.
Just
Thank you, Mr.
for the gentleman's information, Mr. Delaney and I will be dropping a bill next week that actually deals with the entitlement issue and Social Security. You might have a look at it.
Thank you for your leadership on this. It needs to be done. Thank
Absolutely. I yield now to my good friend, the gentlelady from Alabama.
Thank you, Mr. Chairman. Madam Secretary, thank you for being here today. If you'll just bear with me a minute, I'll get to the question. But the IRS requires the HHS managed marketplace and state-operated exchanges to report account-level information, including the identity of all individuals who obtained coverage and the amount of assistance received by that person. We're all aware about the administration's failed healthcare.gov website launch. However, I'm not sure that most Americans are aware of the fact that the critical back-end data reporting and payment systems used by issuers and CMS were not operating effectively as of last spring. HHS's inability to provide timely and complete transmission of the required reconciliation data to the IRS seems to indicate that the critical back-end systems continue to function at less than optimal levels and are still not fully operational. So we understand that HHS's first transmission of this required data was not provided to the IRS until October of 2014. In addition, we understand that the data that has been provided on a monthly basis has not been shared in full and in a routine manner. Our understanding is that as of January 20th of 2014, the start of the tax filing season, HHS provided the IRS with the following: partial data from the 36 states participating in the federal facilitated marketplace. And this data only covers 2.8 million of the 4.2 million policies purchased through the federal facilitated marketplace. Limited data from HHS managed state-based exchanges for the 9 of the 15 state-based exchanges. So, given the fact that over 86% of the individuals participating in the marketplace or an exchange are eligible for advanced premium tax credit, how can the IRS and HHS ensure that taxpayers are not subject to overpayment, underpayment, or fraud in light of the lack of accurate data for individuals who purchased insurance through the marketplace or exchange?
The data for the 1095s with regard to that issue had been provided to the IRS in terms of that's what's happening as part of this tax season. So the question and the number that you have with regard to the number of people and the data that the IRS received is not a number I have. Love to take it back. Love to understand where it came from. Because in terms of the IRS receiving the information as part of this tax season, they have. And so I'm not sure where that number is coming from, and maybe
Well,
if you can help me.
correct that for me, it would be really helpful
Sure,
because that's the
sure.
information that we have had access
I'd love to follow up and understand where that came from, because the IRS, has the tax information, and certainly from the we're responsible for the federal marketplace. With regard to the state data, that's a state responsibility.
Sure.
But those numbers were not at all what I would have, I've reviewed in terms of the state numbers. So if we can understand that, I'd love to follow up.
Okay, that would be appreciated. I think, well, in light of the fact that you have differing numbers than I do, I guess the follow-up question would be, these back-end systems, are they fully operational? Is that the
So
position
there are
that
two
you're
different
taking?
issues when we talk about, I think, the reference to the back-end systems, because at one point you referenced the insurers and the question of their relationship. This is about the individuals in terms of the IRS, because I thought when you started and you mentioned the insurers, the question of the back-end system with regard to the insurers, everything is automated. Do we believe it should be done in a way that is more technologically easier? Yes, and we're going to continue to work to do that, and we're going to work every day to make that. But the automated system that we're currently using is a system that we use for Medicare Advantage and Medicare Part D. And so the system that we're currently using is a system we've used in other ways for other things. Do we believe this can be made easier? Yes. Let me be clear about that, and we want to work towards that.
What, as it relates to consumer data hacking or unauthorized activity, can you talk about, do y'all have a number of events that have occurred, and can you give the scope of the events and then what you're doing to protect consumers
With regard
from
to
this?
personally identifiable information, we at this point have not had a malicious breach of the marketplace with regard to that data.
Okay, all right.
It is an important issue, as we've seen with private sector companies. It is something we stay on top of. We have come in and put in place a strategic approach that actually is about how you set up the systems, the prevention, and the constant monitoring to make sure that we are staying on top. I guess I just want to emphasize it's a very important issue. We have not had a breach, but it is something we want to make sure that we continue to focus on. It is also a part of the funding.
Okay,
So
my
an
time
important
has
thing.
expired, but if you would please follow up on the first question, and I'll
Be
make sure
happy
and
to.
give you
Would
where
love, that
we
would be
received the
helpful.
information.
That would be helpful. Thank you.
Thank you, Mr. Chair.
Thank you. We have two gentlemen from Pennsylvania who've yet had an opportunity to ask questions, but in the interest of partisan balance, I want to... Well, no, we're just moving down, giving everybody an opportunity. But my friend, Mr. Fattah, is recognized for 5 minutes.
Thank you, Mr. Chairman. And in great congressional fashion, I'm going to say a group of things, and then I'm going to ask a question. All right? First of all, I want to thank you for your extraordinary leadership at the department, and a great many things in particular. But first and foremost, your visit to Philadelphia on Dr. King's birthday and at the Project Home with Sister Mary Scully, and it was great to have you. The work that you've done on the Affordable Care Act, Pennsylvania has been extraordinarily benefited by the enrollment process. We have hundreds of thousands of people who now have coverage in the latest enrollment process with over 11.4 million people signed up. So I want to congratulate you on that. I want to mention that the work that the department is doing as part of the BRAIN initiative that I've been so involved with. I want to, Francis Collins and NIH, but across the board, the administration has done just some very important work. We have some 50 million Americans suffering from one of the 600+ brain diseases or disorders, and we have a lot of progress that we could make in this regard. Obviously, it's a tremendous cost, but beyond the cost of things like Alzheimer's, and it's really the families involved. I mean, just so I want to thank you for that. And then I want to ask my question, which is about our new governor in Pennsylvania, Governor Wolf, who wants to proceed now in terms of Medicare expansion as part of the Affordable Care Act. And our previous governor had wanted to do, had a proposal that had been, the department and the state have been jousting back and forth about, and there was some agreement. And I want to know how we can now transition and how you see the transition to full Medicaid expansion.
The governor can come, and it actually can happen really, I think, two different ways. It depends on how the governor does or does not want to implement the existing agreement, and he has that opportunity to do that. If he wants to do anything different in terms of the agreement, we welcome that conversation and look forward to it.
Thank you very much. Thank you, Mr. Chairman.
Thank you. The long-suffering other gentleman from Pennsylvania, Mr. Dent.
Thank you, Mr. Chairman. I'm not suffering, but thank you just the same, and congratulations on your chairmanship. Secretary, great to be with you this morning. I want to follow up on some question I think that Mr. Womack just discussed, and I came in during the middle of it, so I may be a little redundant. I hope I'm not, but my home state's legislature, like yours, has taken up action to expand access to naloxone or Narcan. I know you got into that. In fact, I'm holding a hearing in my own district on this very important subject in rural Berks County, Kutztown, to discuss this. We've had numerous deaths of overdose from heroin. Would you describe, how would you, I guess, describe the HHS budget proposal? How would it help states like mine? And how the department plans to reduce overdose deaths through ensuring broader access to naloxone?
So I think it's both about the access to naloxone, but one of the other parts of the budget is the importance of supporting the states in their prescription monitoring plans, because that gets to this core issue of the starting point of the prescription. And so it's both about naloxone, making sure that we understand its use and make its use easier in communities and support that. That's some of the work in SAMHSA that we'll be doing. At the same time, we need these stronger prescription deadlines and guidelines. And so those are two different things that we're working on. One is more from CDC and that part of the organization. The other is SAMHSA working with communities as they're trying to work through the issues and do the implementation of the naloxone and things like that on the ground.
Thank you. As we discussed yesterday, thank you for your call. Ebola, of course, is a very important issue, and I'm pleased to say that there's a lot of activity in my congressional district on that issue. One company, OraSure, is developing rapid diagnostics, working with CDC and others, and NIH. But I'm also pleased to say that there are two health systems in my district too that volunteered to make investment to become designated Ebola treatment centers. What advice should I give them about the process to take the next step to be considered a regional center?
With regard to the consideration of a regional center, I think that's something that coming through ASPR, the Assistant Secretary for Preparedness and Response, and working with HHS's regional office would be the next step on that part. The other part that I think they should do is be in close contact with their state health departments, because the state health departments are going to play a role in two things. One, as we work through where the regional location will be, but second, some states will actually also have additional hospitals that will be treatment facilities in addition to the issue of the one, the regional designate. And that's so that we have a capability to expand if we ever need it. At the point at which we were in the middle of the Dallas situation, we did not know. We thought we had a sense, but one had to plan for the worst case. So those are the two places that I would encourage those hospitals to speak.
Thank you, and we'll follow up. And just briefly to Madam Secretary, on move the LHHEAP. Given the low cost of crude oil, which is translated into heating oil prices being on par with and sometimes lower than the equivalent natural gas price, why would HHS be using valuable LHHEAP program dollars to switch recipients' fuel systems at a cost of $10,000 on average when there's no real need, given the current price of fuel? Current LHHEAP funds could go to help consumers make simple, cost-effective upgrades that immediately reduce emissions and save them on their monthly bills to help pay for the fuel they're currently using. And do you really think it's appropriate for HHS to use LHHEAP rules to discriminate against homeowners based on the fuel they use at this time?
With regard, I have focused on actually the movement of the money in terms of LHHEAP during this winter season since I've been at the department. With regard to this specific issue, it's not one that I've looked at and I will look into.
Yeah, I'd appreciate it, because there's some concern that why make the conversions now when the price of fuel oil is comparatively low, and it seems like there's some type of discrimination based on type of fuel used, and I think there's a better way to allocate those light heap dollars, so I appreciate you get back.
And as a part of our budget proposal, I think, yes, the ranking member mentioned we are flat, but I think one of the things that's important is actually we are trying to put in contingency and other monies that would be more targeted to when there are changes, so we can act and react in terms of pricing. And so that's an important part of what we have done, and I will look at this. But as we think about this in the context of the budget, we've tried to create a situation where the additional funds would be something that would help us be more flexible in reacting to situations that we can't always predict, which is why I'm attaching it to your issue of the changing price.
Well, I'm going to yield back since I have time left and just doing my duty here, Mr. Chairman.
Thank you very much. I appreciate your generosity. Just in the interest of trying to get as many questions in as we can in the limited time that we have left, I'm going to reduce the question time to 2 minutes, if I may, for all concerned for a second round. So with that, I recognize the gentlelady from California.
Okay. Madam Secretary, I've had a long-standing concern about the use of psychotropic drugs to treat children with behavioral problems. And in the past, my colleague, Representative DeLauro, and I asked the GAO to issue a report. And what GAO found was that the children on Medicaid are prescribed these medications at twice the rate of privately insured children, and that 18% of foster children were prescribed psychotropic medications, often in amounts that exceed the FDA guidelines. So I was pleased that your budget calls for a 5-year demonstration project to encourage states to provide evidence-based psychosocial interventions that could be used hopefully in place of or in combination with drug treatment. So very quickly, I have 3 related questions. First, has the department considered reaching out to organizations like a Boys Town Hospital that have had considerable success in reducing these psychotropic medications? And also because according to the GAO report, psychotropic drugs represent the single largest expenditure in Medicaid. That's over $2.8 billion in 2007. So has CMS done any research to determine whether reimbursement policy may be feeding this problem? And also, what research has been undertaken to address the problem that's so critical to the children's long-term development, and what percent of research is focused on looking at this?
So first, just want to say thank you. It is that study that I read when I was at OMB that led me to very strongly support this, and now when I got to HHS, work to expand the effort. So thank you for that. That piece of work is part of what made this policy. The policy is actually to pursue, and that's what the dollars are to pursue, so that we get to the best practices. I want to check specifically if we are working with not-for-profits. I know that we're working with states, but you've raised an issue of not-for-profits. We need to check on that. With regard to the issues of the payment, it is an issue that we are looking at, if in terms of how we are doing our payments, if that is a part of the issue that is exacerbating it. So that will be a part of what we are doing.
Madam Chairman, I have other questions, but I'm going to hold mine and submit them for the record to you so we can indulge the other members. I want to move to the gentleman from Idaho.
Thank you. Quickly, I appreciate the fact that your budget fully supports the estimated contract support cost for Native Americans.
Yes.
You say that you want to modify the program by reclassifying as a mandatory appropriation in 2017, not this budget, but next year's budget. Whenever I try to do something on mandatory side or try to put something in mandatory, I have to find the pay for. How are you going to pay for it? Have you come up with that yet? Have you thought about how we're going to make it mandatory?
So with regard, because we have done the entire budget, we have paid for everything within the budget. And so the question of one-for-one pay-fors, we have our pay-fors throughout the budget in terms of both on the mandatory side as well as on the discretionary side in terms of our puts and takes. So it is embedded within the budget, our payment for it. There is not a specific pay-for it, but we believe it is the right place to be with regard to this issue of the contract support costs.
I don't disagree with you. On the other side of that, the mandatory funding for community health centers is ending October 1st. Have you proposed continuing making that mandatory funding in the future?
Yes, it is a mix. In our budget, it is a mix, and we believe it is important to continue that on the path that was done as part of previous legislation.
Thank you.
Thank you. Gentlelady from Connecticut.
Thank you. On child care, just very quickly, It's pleased to see $370 million increase for child care. A portion is requested is $100 million pilot programs. Can you talk a bit about that? And then if you can just talk about the consolidation on food safety as from your perspective of that effort under HHS and those responsibilities. And
so the 370 is to implement the bipartisan child care reauthorization that you did with regard to the specific of the 100 million. There are populations, parents who actually work differing hours, people who work at night, and so there are a number of different populations that aren't being reached by our child care, and so we need to make sure that for working Americans who may have circumstances that are not the traditional circumstance, that we're thinking about it. That's what that money is about. With regard to the food safety issue, what we're trying to do is get a system that is simpler and higher quality, and because pieces sit in different places, everyone uses the pizza example, that if it's a cheese pizza, it's at one place. If it's a pepperoni pizza, it's regulated by two different parts of the government. That's a part of what we're doing as we propose this effort.
Well, you're putting legislation forward.
At this point, I think this is an issue that we want to hear and understand where the Congress is.
Gentleman from Arkansas.
Yeah, just a couple of real quick questions. I'm going to go back to Ebola for just a minute because we knew that it was on the material threat determination list for more than a decade, but therapeutics and vaccines not fully developed. Can you tell us, I'm not asking you to pull out your crystal ball and predict the next Ebola, but what else is not on that, that's on the threat assessment list that we are still not entirely prepared for, and where we should focus maybe some of that concern?
So I think the most important place for us to focus our preparedness in terms of we need to continue working on those lists, and whether it's airborne things or things like Ebola, we need to continue that. But the place where I think we can make the most progress to protect the homeland is by putting in place the things that are part of the global health security agenda. And why that is the case is because when you saw what happened in Nigeria, we all know Nigeria had the cases. They had up to almost 20 cases, but it didn't spread, and it's because they had the ability to do the prevention, detection, isolation, and contact tracing. And so putting those pieces in place in the places where these things will come from is a very important step, and one of the ones I think we need to emphasize most.
Assuming that there's always going to be insufficient funding, and I think that's an accurate assumption that we can all make to deal with these kinds of issues, how would you prioritize?
With regard to the global health security agenda monies, we prioritize those by country need, and the other thing we have to do, and we are doing, is we got to get other countries to help pay.
Have all the smart people in your organization calculated the total cost to deal with all possible threats, what that number would look like?
I don't think we've done it in an aggregate fashion in terms of all total costs in terms of modeling it that way. I think what we do is on the pieces we prioritize, in the area you were talking about, or the anthrax issue, or those issues, we prioritize that way.
Just as an aside, Mr. Chairman, we were all, most of us were treated to a visit up to NIH, and I found it pretty impressive that there was a young lady there, I want to say her name was Sullivan, that was working back in the vaccine area, that had pulled out her, in fact, you made the comment that that must have been her junior high notebook.
It was her notebook, and she had worked on the Ebola vaccine. I've met with her.
Amazing.
Yes.
That what stood out to me, and to her credit, was the fact that she had done all of this work before, when it was not even really,
no one
it was
cared.
more of an afterthought than anything else, and she was able to go back to that research and expedite by as much as, I think, 6 months the time it would take to respond. Anyway, I just thought that was a credit, and speaks well of the NIH.
Okay, Mr. Harris, you'll have the last questions.
I guess I sit between us and lunch. Just very quickly, as you know, the ORR grants provides grants to institutions that provide housing for the UACs. And, I was very disappointed by the Christmas Eve regulation that basically set regulations on some of these faith-based. 6 of the 9 grantees are faith-based, and they do feel that their religious freedom is going to be impinged by these regulations. And, you find yourself with a department that's really the tip of the spear in what many people, myself included, feel is a war on religious freedom in this country. I would hope that you take their comments, the comment period ended Monday, into account for the final regulation. When your predecessor was here last year, I asked her about the non-transparency of abortion coverage in exchanges. You know, and the department comes out with their definition of separate payments that is just mind-boggling because it's not a separate payment, which would add to transparency. So I would hope that you would take some steps to modify the rule that make it really a separate payment, which provides some transparency. And just finally, a question for you. What's come to my attention is that a lot of the plans on the exchanges are putting all the drugs for a given disease in their top tier. So what you're doing is you're basically giving people a plan that covers a routine physical, but God forbid they get a disease where they require an expensive medication. Tiering is actually doing two things. One, it actually discourages them from taking plans, so it actually it puts high-risk people in. It doesn't allow them access to really all the plans. And the other one is, strangely enough, tiering is actually supposed to discourage people from taking the top-tier drugs because a lower-tier drug would do the same thing. But what we're finding is that all the drugs for a disease are being put in the top tier. Is this adverse tiering something that the department is going to do something about in these plans?
With regard to the issue, as these issues have come in and been raised, they've been raised in some specific actually disease areas, HIV and some others. We are continuing to look at them on a case-by-case basis and overall. And so when these have come in, we are having the conversations and understanding and working with the states and the insurers to talk about these issues. As these things come in, we want to work on and figure out how we can create a situation where people do have the access, which I think is your point, to the quality care they need.
Thank you
We
very
agree
much.
with that.
I yield back.
Madam Secretary, I want to thank you for your testimony today. They didn't lay a glove on you, not surprised, but we very much appreciate you
I have a
taking
long
the
to-do
time.
list.
Well, I suspect it'll get longer once questions for the records arrive. But
I do as
seriously,
well.
thank you very much for your service. Thank you for your cooperative and open attitude. We very much look forward to working with you as we sort through these issues and find the appropriate balance. So
Thank you.
have a good day, and thanks for being here.
Thank you. Thank you.
or whatever her name was, you know, she like erotic pictures and all that. She'd be naked all the time.